All right, welcome to the webinar for the new to Medicare people. This webinar will be covering claims basics. I'm Tom Ryan and I'm your host for today. Today I'm joined by Karen Curtis from my team. She's going to act as your chat moderator, kind of get you through all those different things. Want to remind you that if any time you have questions, please feel free to put them in the chat and we'll get that information to you. Someone pointed out to me that my slides do have the wrong year on them. I do know that it is 2025, not 2024. However, sometimes I get a little confused over which year I'm supposed to be using. So let's do a little housekeeping here. If you need the presentation, it is available in our training center. Now, I will stop and just show you in a moment how to get there. And the reason that I'm going to do that is because this is for those new to Medicare people. So a couple people commented they weren't really sure what we were talking about and where that is. It is on our website. I will tell you that the training center is linked. So if I use right on the slide, I can use the word training center and go ahead and open it up. What I'm going to do is show you how to navigate there to get that. We'll talk about a couple of different components. Again, send questions in chat, and then at the end, we're going to give you a survey. We do really value your feedback on the survey. The survey really does help us a lot. Gauge what you want in the future, how this education helps you, all of those types of things. But as I promised, because this is new to Medicare and a couple of you did ask about our training center, I'm going to start there. Again, before we really get too far into the content. First thing I want to make you aware of is when I say ours, I'm talking about the WPS website. That is WPSGHA.com. If you notice right up on the top, in the center, there's the word training center. This is where we store all of our training material, have training information available for you. When you open the training center, if you scroll down underneath the login for our secure site or our portal, you'll come to the different boxes and categories within the training center. These are just our topics. Live events is what we're going to look at. Encore is where the recording will be. But live events is where you're going to come and you can actually register for an event, open up links to events, and get the PowerPoints. I'm not going to download it. I already have this available, but you could download the PowerPoint and see what we have available for materials. So if you guys want more than that, please put that back in chat. Hopefully that was what you needed for those that are new to Medicare and we're struggling with where to find that presentation material. What will happen is in the live events section, we will take that down today. The presentation will either come down tonight or tomorrow. I'm not sure exactly which one, but by noon tomorrow it will be down. We will then post the recording of this presentation into our Encore section, which I also showed you, it's right next to it. The recording itself will be housed on YouTube. The Encore section does contain a player and will have the PowerPoint available. So hopefully you have all of that information. Oops, a couple of you have probably heard this before, but I just want to remind everyone that this information is a tool to assist the Medicare provider community. Because Medicare does change and sometimes changes pretty frequently, we want to make sure that you're getting the most current rules and regulations, and those are available on the CMS website. Also, I did take questions in advance, and you've already heard me address one of them, but I want to make sure that you're aware that the questions and the way that I'm going to answer them are based on the information that we're given. So if you need more, I really would like you guys to put something into the chat, okay? Put something into the chat. All right, so remember, the Encore playlist will have this available for you. What are we going to talk about today? Well, first of all, I do want to explain the Medicare claims process for people with under 6 months of Medicare experience. Because it's for someone so new to Medicare and really getting started, we're going to focus on a high-level overview. I will work on information from a UB04 or 837I claim. That's one type of claim that Medicare accepts. Again, two different ways to get it to us, but it's the same type of claim. It's a facility claim, institutional claim. I will also work information from the CMS 1500 claim form or 837P electronic transaction. That's the second type of claim. That claim is from a professional, a supplier, something like that. We'll talk more about that in just a little bit. In order to do this, you talk about the claim experience as an overall experience. We're going to focus first on the patient responsibilities. We did have some questions that came in regarding that. Second, we're going to focus on the provider responsibilities. So what does someone that you work for have to do before you submit a claim to Medicare? The last portion that we're actually going to focus on is the Medicare responsibilities. What do we do once we get the claim? How do we look at it? All of those types of things. Hopefully that will get you through the, again, high-level overview. One of the first questions we got in, and I will address this a bit more as we get into it, is what do I use to reference for the patient? And the website's medicare.gov, and we're going to go through that in just a few moments. But I do want to remind you that when we talk about the patient responsibilities, I'm going to highlight what Medicare says they should do. Now, Medicare is the Center for Medicare and Medicaid Services and the federal government. The patients are often referred to as Medicare beneficiaries if you're talking to someone from Medicare. You're going to refer to them as Medicare patients. Typically, it's the same person, it's just how we refer to them. So I'm going to try to use the word patient because that's what you'll know them as. They're your patients, they're your Medicare patients. All right, so while I'm going to go through these responsibilities, remember, we can't force the patient to do anything and neither can you. So there are some of these responsibilities that I've gotten some pretty negative backlash on or comments on, and I understand that it's not that you're backing out to Medicare, you're saying, hey, the patient's not willing to do this. We do understand that, and I'll talk a little bit more as we go through, but I do want to recognize that we did get those right away. Um, let's move on. Let's talk about one of the big ones for them, and this is the Medicare and You handbook. Now, here's why this is so important for the patient and for their responsibilities. This is their policy guide. How many of you in your insurance policy got a guide, got an explanation book, explains about your insurance and whatever you have to know about that? I did. When I started with my company, and when we go through our insurance changes each year, we get these guides. The same thing happens with Medicare. Medicare sends the patient a guidebook. Now, whether the patient reads it or not is not something that is controlled by Medicare. Now, when we say sends a patient, they could reference it to one household. So let's say a husband and wife live together, they're going to send the guidebook to them. This is the patient's Medicare guide. It is what they're required to know. Very little information is contained within it according to the provider community because the provider community has to know the rest of the information. And let me show you this guidebook so you understand what I'm talking about here. So I'm going to jump back to the website first of all. And the first thing that I want to do when I'm on the website is go to the patient portion of the website for Medicare, which is medicare.gov. So you will not use this typically unless you're looking for something for your patient, but it is a great resource for you. We'll talk more about yours in a little while. On medicare.gov, start with the basic section, and it's going to be Medicare and You handbook. What's great about this is it'll give you the option to look at a PDF. You can view all the information. Again, there's a variety of other things you can do and refer the patient to, but this is going to be your big one. All right, I'm just going to scroll down and I'm going to download a PDF of this. You can, again, have this sent to you. There's still some other ways, which is down here, that the patient can ask for only one copy, a variety of things. You want to look at it here, download the handbook. When it opens, it's going to tell you, first of all, this is a 128-page guide. If your patient says to you that there's more information in theirs, that is correct. What is contained within theirs is the regional information for Medicare Advantage or Part C plans. That would not be contained in the national handbook, but it is contained in theirs. So the one that you get to look at doesn't have all of the exact information, but it does contain the basic benefits. It'll walk you through all the different contents, the different parts, the benefits, all of those different things. So I just think if you're really looking for something that's going to help the patient and to answer the question, yes, this is probably one of your best starting points, but don't be scared of the rest of the handbook. I'm sorry, the rest of the Medicare.gov website. So when we talk about this handbook, yes, it's the patient's responsibility to know this. The question was, is that why we don't have to give an ABN? Yes. An advanced beneficiary notice of non-coverage is to indicate that a service is not medically necessary. It can be used and is a nicety, but does not have to be given when it's a non-covered item. This booklet right here explains what's non-covered. Non-covered for Medicare means the law says it's not part of our benefit package. It's not going to ever be covered, even if it's medically necessary, even if the doctor fights with it to be medically necessary, because the law says it's not covered. So hopefully that explains and answers those few questions and why I put the information on the handbook in particular in here. All right, we're going to go back to our slideshow. We're going to move right along here. It is the patient's ultimate responsibility to keep their records current. This does include the Social Security Administration record or the Railroad Retirement Board. Now, we do not deal with Railroad Medicare. We are the Part A BMAC, and we deal with the Social Security Administration eligibility patients. but we cannot update eligibility. That is on the patient to do that. Someone did ask very specifically who's responsible for the Medicare Advantage plans. Well, I wasn't really sure where you were going with that, but it's ultimately the patient's responsibility to make sure that information is current and up to date. Um, if you want more clarification on that, could you please put some more information back into the chat for me as to exactly what you want to know? You know, who's responsible for which portion of it, where do you go from CMS, any of that type of information. I just wasn't really sure where to go with that question. Now, I will tell you, along with the patients keeping this information up to date, they also are responsible for keeping their Medicare primary payer information up to date. So that's why the patient is referred to the Benefit Coordination and Recovery Center. Thanks for that question. That was a great question. So yes, the patient is ultimately responsible. I will talk about during provider responsibility what you can do should the patient not do that. For those of you that don't know, some patients don't want to do it or don't frequently do it. With that said, I do want to follow up with that question and complete that by showing you where that is on the CMS website should you need to get them information. Now, this is the one time I'm going to tell you the BCRC is a universal number, so it's okay to go to the website you're used to, and this is going to be cms.gov. cms.gov is the provider, their representative, the Medicare administrative contractor, which is us as your claims processor, and to everyone else's website except the patient, right? That's medicare.gov. When we're on here, if we go to Medicare, we kind of scroll through this side over here. Now I said scroll through because I got to go all the way to the bottom to find the coordination of benefits and recovery. It's the second to last link. When I select that, it's going to allow me to look up a variety of pieces of information. Easiest way, go to the first one on the left side, and that's overview. Once overview opens, don't need to look through all of this, just scroll down again on the left side, come to the second to last link, and that is contacts. This will give you the information, and yes, you can give the patient this 1-855 number. It's a toll-free line. It's available for both patients and providers should they need it. So yes, when trying to get that information updated, this is the information that they will need. So hopefully that answers the question on that. Again, if not, come back to me and we'll get you through that part of it. Next, the patient is responsible for giving you all insurance cards. This is whatever policy they have and whatever is available and going on with them. Now, I do want to point out a couple of things with these insurance cards. First, there are two of them on the right side, and that's the one on the furthest right, which says Railroad Retirement Board on the bottom in the red banner, the one directly next to it, which does not have that. This would represent which portion of which portion of the federal government made them eligible. The Railroad Retirement Board is a separate contract from traditional Part A and B Medicare. While it does contain the same benefits, it is a separate contract. The Social Security Administration, which is who we work with, issues the second one from the right, while the Railroad Retirement Board issues the right one. And you can see that down in the bottom. Next to that, you also see a blue, this is just a sample card, but it's a Blue Cross Blue Shield Blue PPO. This is a Medicare Advantage style card. They will all look different. So while the first two cards I talked about are standard, the other cards are not. This is a Medicare Part C style card. And the last one actually says Supplemental Plus. This is a Medicare supplement card from Blue Cross Blue, also from Blue Cross Blue Shield. And you can see how they differentiate. Okay, this is a supplemental. This is a Part C plan. And I did that on purpose, trying to pull two different ones so that it was the same company, but showing you that it's different. What makes this supplemental? The word supplemental is on here, which also then indicates that it follows Medicare. It's not a replacement plan, and that's key. It has to be written as the policy to follow. Otherwise, it would be primary. So if they had a Blue Cross Blue Shield card and it didn't have the PPO, Medicare Plus PPO, or the Supplemental Plus, odds are that is a primary insurance to Medicare, which must pay, but they're still going to give you a card for it. And that could be an employer-based plan or a variety of others, such as private purchase. Okay. What else is the patient's responsibility? Well, hey, they got to give you all the primary payer information. Now we say primary payer, and then we say, hold on, it's not really about the primary payer. What they really do have to give you is all of the payer information, and then the provider has to determine which one is primary. So we do have an area on our website to do that. And we'll talk more about that in a little while. We get into provider responsibilities. As I talked about, it is their responsibility to update the Benefit Coordination and Recovery Center. And here's the links to get to that information. If you look at these two on the bottom down here, the top link is the one that I showed you. It's the contacts. The bottom link is this booklet. This booklet is a Medicare.gov booklet. So this is the patient booklet. So if you're looking for a resource to help with your patient, definitely take a look at this. If you don't feel it's going to work for you, that's okay. But I wanted to at least have a resource of some sort to help you with that. The patient also must give you permission to file. For those of you that are not familiar with this, many practices use a signature on file card. They sign, they say, hey, you're authorized to submit to proper insurances, da, 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 da. And then when you build a claim, it'll say signature on file. Hospitals do this at admission. Other providers do this at various points, so they can do it once in a lifetime and actually have a signature on file for sometimes. So they do have to give you permission to file. The question came in is what happens if the patient does not give permission? They do not want this filed. First, that is their right. As long as you've documented that they don't want it filed, you are not violating the federal law that says you must file it, because this is the patient's insurance. This is theirs. The thing to remember is one, you must document it, and you must file it within 1 year should they give you permission at that point. Okay. So again, without permission, who's responsible for that entire bill? The patient or a different supplemental plan. The patient or a different supplemental plan. There are also times when the patient will say, no, just bill the primary insurance and don't bill Medicare. That's okay too. But again, document that. And in which case, whatever the primary does leaves them responsibility. It's going to be the patient's responsibility because you can't bill Medicare for that. So they do have to give you permission to file. We also had a unique situation question come in that I was not familiar with, but I did have to look it up. What happens if the patient doesn't want a certain set of services billed? This case, they specifically targeted behavioral health / mental health services, and the patient doesn't want anything in that category billed. Document that. So just like with any other claim, if the patient says, I don't want whatever it is billed, please document that. We did talk about this, but I just put this one in there as a reminder. Again, Medicare.gov is definitely going to be your patient place. This is where you're going to send them. I will tell you that if you look up on Medicare.gov, you will not see our phone number, nor will you see any other MAC. The number the patient calls with their questions is 1-800-Medicare, 1-800-Medicare, which for those of you, it translates to 1-800-633-4227. If they call us, we cannot help them. We are a provider base or a Medicare administrative contractor only working for the providers. So hopefully I got through a variety of those different questions. We're going to bring us to the first set, which is the patient responsibility questions. But before I do that, I do have another one that came in and then as a pre-submitted question, although I've addressed a lot of them already. Do we have a recommendation for anything to refer the patient to? First, my first recommendation is start with Medicare.gov. I will always recommend this. On Medicare.gov, the patient also has a portal that they can access just like you do, except yours is on our website, which we haven't got to yet. But they can access claims. They can access a lot of information on their own portal. So refer them there. If they have questions on using the portal or other registration, that is a 1-800-Medicare question. Again, 1-800-633-4227. You must also be allowing them to call 1-800-Medicare should questions arise or they are confused. Now they can call before they come to see you, but if something happens during a visit or something and you're explaining information, sometimes it's best to call with them, or sometimes it's best to allow them just time to call. But please make sure you do that. So when we talk about help, we want to make sure that you're referring to Medicare You handbook, Medicare.gov, and any of the resources such as the MSP booklet that we have, or 1-800-Medicare. Those are the best resources we have. Karen, at this point, do we have any questions in the chat?
Tom, we haven't had anything come through in the chat yet.
Okay, I'm going to go ahead and go through the next section, which is the provider responsibility, and then I'll stop again for some questions. So if you have something that comes up, might be a little more relevant to you because this is what the provider needs to do. Now, I will tell you, in looking at this particular course, and because it is new to Medicare, people with under 6 months, I did not go quite as in depth as I would for someone who's talking about very specific claims and coding and things like that, and what we can and cannot handle through those types of things. I kept it higher level on purpose. And again, we do offer a variety of courses that will help you with the new to Medicare part if you're looking for more on any of these given components. But the first thing that a provider does have to do, and they are required to do this, and this was one of the questions, is do I have to enroll in Medicare? And the answer is yes. As a provider, you need to enroll in Medicare. There are exceptions to this rule. VA providers cannot enroll in Medicare to be paid, but they can enroll in Medicare to make sure that they can refer to an outside source provider. It's just an example. There are also what we would term providers that are not Medicare eligible for payment. So while they could see a patient, they're not Medicare eligible for payment. So you want to make sure you meet all those different responsibilities. It is the provider's responsibility to do their initial enrollment. That's when Medicare decides whether or not you meet all of the federal criteria. This incorporates things like, do you have a current state license? So though it's a federal criteria, the criteria says it has to be a current state license. So it's going to incorporate all those different things. During the initial enrollment period, we also will expect you to set up an electronic funds transfer. We pay you electronically. Okay, so there's lots of things going on with that. We do expect that you will keep your records up to date. And I know this is my third bullet. I'm going to come back to the second one in just a moment. There are changes within your enrollment, and this is an expectation. What happens if you do not keep your information up to date? We can actually suspend your payments. And then if you don't update it at that point, we can actually start your enrollment process over. So we can actually stop you from getting paid at all. This commonly happens through the revalidation process, however. And for those of you that don't know what this is, the enrollment process, when you start an initial, do a change or anything else, is done, and it's got a lot of information. There's a lot of forms and other things that go with it. Every 5 years, approximately, Medicare requires you to do a revalidation. And this means we look at everything in the enrollment record. So you can imagine this is a pretty in-depth analysis looking at the record, and it requires us to go through everything within that. So we want to make sure that you do that. It is currently a problem that people are not revalidating. And some people say, well, is it really that big of a deal? It is, because you're not going to get paid anymore. We actually will stop payment. Also, if you're a supervising physician of someone like an NP, or I'm sorry, like a PA, physician's assistant or nurse practitioner, and they're listed on your record, do you know that by not revalidating yours, you can stop their payments as well? And we do get those questions. So that was one of the questions that we have. One of the other questions that I did get as I'm talking about enrollment relates to changes. Are there changes that must be completed faster? I'm not sure what you mean by that, but let me just give you a few examples. Most changes do have to be completed within 90 days. However, a change of ownership for an organization, you only have 30 days to do that. If someone is disenrolling, maybe they're retiring, maybe they're moving, whatever, that's a 90-day change because you still want to be able to make sure that you have that continuation. You can submit changes 60 days before they occur. So while you do have 90 days in most cases after, it's 60 days before they occur. So I'm not really sure which one you were talking about there, but I want to make sure that's clear. One other question we got is, can CMS do a revalidation outside of the normal 5-year time frame? Great question, and I'm feeling like this might be from a skilled nursing facility because they're in what is called a special revalidation period right now. It's not 5 years. What CMS has said is, due to federal regulation changing, which was a law that changed, we have to track certain pieces of information. And because of that, every SNF within the Medicare program must go through a revalidation. And all of this must be done by May 1st, 2025. So right now we have approximately 2,500 skilled nursing facilities who have not completed their revalidation. And if you think about it, May 1st is coming up right quick. So please make sure that you do that timely. But that's an example of when it would be a special revalidation period. You're not going to get 5 years. CMS can do that with any type of provider at any time they issue them act to do a revalidation. All right. So once you've done your enrollment, what comes next? You may have heard the mantra that if it's not documented, it didn't happen. That mantra is very true for Medicare. What that means is that if it is not written down, whether handwritten or electronic records, something, if we don't have a record for it, it cannot legally be proven. If it cannot legally be proven, we cannot pay you for it because everything that you do can be taken into law, into court. And we'll talk about that. It's an appeals process. So the documentation is that link between delivery and payment. Without the link, if it's not documented, it didn't happen. So it must be written. Well, that makes sense. Now, again, I did say it could be handwritten. It could be electronic. Mostly what we're getting, about 95% of our documentation right now is electronic. It does need to be complete. Explain exactly what happened, why it happened, all of those types of things. Then we hit legible. This is one of my favorite ones. Now, the reason that I say it's my favorite ones is it does have a couple of different questions that went with it. One of the questions was they have a provider who tends to use a lot of acronyms and abbreviations that are not normal. I don't know what normal means. I'm going to assume it means that are not within the normal medical realm, but maybe they make up their own. If that happens and we don't know what they are, then it's not considered legible documentation because we can't read it. We don't understand what you're saying. Another question is, does a provider signature have to be legible? My answer to you is no, the signature itself does not have to be legible, but if you can't read it, you better supply us with something so that we understand who they are. So while it doesn't require the signature to be legible, it does require something else going on. And yes, an electronic signature counts. Okay, then you do want to show medical necessity. You want to show authorization for filing, make sure that that gets billed. And then you want to bill in the proper order. So document that you've asked questions, document that you've ascertained that there's a primary insurance. That primary insurance is an employer-based plan, or it's a car insurance, or it is a liability insurance, something along the way so that everything gets billed in the proper order. And that's why you billed the way that you did. All of those are key components to documentation. All right. One question that we got in is we say show medical necessity and preventive doesn't have medical necessity. That is correct. Preventive care is a separate area within the Social Security Act. It's not under the medical necessity section. It's actually got its own section. No, preventive care does not need to be medically necessary. You're trying to avoid something, prevent something. That's the whole purpose of it, which is why it has its own information. So I just thought I would bring that up very quickly there. We did have a couple of questions, so hopefully this will help you understand the questions regarding who to bill first. First, you need to determine which part of Medicare is going to be billed. Is it Part A and B or Part C? Is it a Medicare Advantage plan, which is Part C? Is it traditional fee-for-service Medicare, Part A and B? But also don't forget that if you have to determine if it's railroad or Social Security eligible, which means you build a railroad Medicare, MAC, or do you build the traditional fee-for-service Medicare MAC? A little bit confusing there, but that'll hopefully help you out. But again, look at that card. Look for that red bottom stripe and does it say railroad? If it does, it's Palmetto governments. If it doesn't, then it's fee-for-service Medicare, traditional fee-for-service, which would be WPS. Also, look and see if home health and hospice. While these are a Part B benefit, they have a separate Medicare administrative contractor because of the specialty of the types of service, as does as does durable medical equipment, DME. So you want to make sure you're billing those types of codes to the correct contractor, otherwise you're not going to get paid. Also, you need to determine, is there primary or supplemental insurance? So the patient hands you a card that says Blue Cross Blue Shield. If you jump back to my few slides there, remember on the patient section, I gave you two different examples, and one was actually a Part C. Another one was a Medicare supplemental plan, but there's a third one, which would be an employer-based plan, which would be a primary type of plan. So where does the insurance fall? Does it need to be billed before or after Medicare? And that's your job to determine that. So once the patient tells you that they have it, you get to determine that. Okay. You can do that in our system, and I'm going to talk about that in just a few moments. You must also determine if you should bill another provider. This is called bundling. Sometimes some people refer to it as overlapping. And what happens is your overlapping claim, outpatient claim, overlaps an inpatient stay. So the Part A facility that the patient is inpatient in is what causes this to be another provider. You have to bill the inpatient must incorporate it onto their claim. And then they pay you, we pay them. Whew, lots going on there. For those of you that are not familiar, there's also skilled nursing facility consolidated billing. If you want a little bit more information, throw that in chat. I can get you some more information. But essentially, a skilled nursing facility is not the same as a hospital. Their bundling system works differently, which is what consolidated billing is. Because a skilled nursing facility isn't qualified to do all of the services, they have certain criteria that says this can be billed to them and this cannot be billed to them, but it's still another provider, and it's just determining by procedure code should that provider be billed or not. And the provider is the skilled nursing facility, just like a hospital would be the acute care hospital or the critical access hospital, the inpatient psych facility, etc. And then there's also, should I just straight out bill the patient? We talked about that briefly when we talked about the patient knowing a non-covered item. So never covered, not going to be covered. And yes, you should bill the patient for those. Also, did it get processed? Did the claim come in and we processed it and it's great? And it went to deductible. Don't write that off. Bill the patient. Now, if you say, hey, I billed the patient came back and said, I can't afford this, and here's why, and I've got my whole criteria established with that, and I write it off on that one patient under that one on a claim by claim consideration basis or on a patient by patient consideration basis, that is okay for Medicare. You have now established why you're writing it off. However, do not routinely do this. That is considered providing a free service and can lead you into a fraud and abuse investigation. However, WPS is not the contractor that does that. So you would be contracted under a different contractor who would go through that process. That's a big old long process, and we do have a whole video on it on our website if you're interested in that. It's a fraud and abuse video. So hopefully I got everything in there. If not, throw some questions back down in that chat for me, and I'll get you some more information. Completing the claim. So yes, you must complete a claim. That was the first question I wanted to answer right off the bat. Now, someone said I'm a professional and I opted out. Do I have to complete a claim? No. There's a big difference. An opt-out provider is a professional provider who is allowed to not deal with Medicare, but they do have to do a special process to say, I'm not dealing with Medicare, which then says you're going to waive your claim rights. Okay. If you have not done that and you see a Medicare patient, regardless of whether or not you have enrolled, you must then enroll and get the claim process, get it started. Okay. All claims must be documented. In other words, in order to bill a service, you must be able to support it within the documentation. Remember, the documentation has to translate. Many of you will use coders and billers to do this process, and that's fine. If it isn't documented, should it be on the claim? And the answer is no. Also, someone asked about rule out diagnoses. Typically, a rule out diagnosis is not on the claim. It's not what they're being seen for, but it is within the documentation. So please keep that in mind. Sometimes a rule out diagnosis will be incorporated onto claims for tests or certain diagnostic services. That's understandable because that's what you're trying to look at. So there's no like cut and dry answer to some of that. If you have a more specific situation with that, if you could provide me a little bit more information, I might be able to help you a bit further. Again, I've already said this, but we do accept 4 different claim types. 2 of them are for facilities and 2 of them are for everyone else. The facilities, you will bill either on a UB04 claim form or the 837I electronic transaction. The elements do translate to each other back and forth, so please make sure that you are looking at that type of information. For a professional or a supplier or a variety of others, you will bill on the Part B type, which is the CMS 1500 claim form or 837B electronic transaction. In this case, Part A and B does not reference a benefit category. It references how CMS uses the line of business. To the person who asked me the question, can I make CMS be clearer and stop using things for 2 or 3 different meanings? I can't do that. What I can do is explain the differences of how they're using it. So when we talk about a Part A, we're talking about a facility. Okay? Part A does bill both Part A benefits and Part B benefits. Why? Because they do outpatient claims, even though they're billing on the 837I or the UB04. We talk about Part B in this example, given how CMS references the line of business, we are only talking about outpatient, therefore everything else, which could be professional services, which could be independent diagnostic testing facilities, which could be suppliers such as ambulances, labs, etc. Okay, so hopefully all of that makes sense. I apologize for the confusion for the person that had that question, but hopefully I did do a better job of helping you understand what we were talking about there. And remember, yes, you have to file a claim. The next question is, how long do you have to file a claim? And the answer is providers must file within 1 year from the inpatient date of discharge, or if it's an outpatient service or a professional charge, it is 1 year from the date of service. Date of service. This is not about claim type. This isn't about anything like that. It's just, is it inpatient? Then you use the date of discharge. If it's not inpatient, you have 1 year from the date of service. I was very specifically asked about exceptions to this. And part of that question was, is a primary payer exception allowed? And the answer is no. If it's a primary payer that did not get this done, you should file it timely within the 1 year and let it deny. On the other hand, the general exceptions are in the Medicare Claims Processing Manual. The Medicare Claims Processing Manual is available on the CMS website, and it is a day-to-day operating instructions. So I want to stop for a moment and I want to jump back, and we're going to go to the Claims Processing Manual to try to answer this question. So hopefully this makes sense to everybody. First thing I'm going to do is scroll back up, and I'm going to go to Medicare. Now again, I'm on cms.gov, Medicare. I'll scroll down, I'm going to go to Regulations and Guidance. Regulations and Guidance. Inside there, we're going to go to Manuals. Manuals is the first one on the left side in the body. When we open that, go to the left navigation and just go to Internet Only Manuals. You will see there are a variety of manuals listed. As I stated, this is the Medicare Claims Processing Manual, which is a publication 100-04. See that right here. Click on the number, it'll open it up, and now you get to pick your chapters and your sections. What's great about this is just in general billing requirements. That's where the timely filing information is. If you don't want to try to scroll through this, you can use Control and F, which is your find feature, and you can say timely. If you're like me and you happen to know where it is, you will know that you need to go to section 70 anyway. So that's where you're going to find that listed. You can actually see, if you read down here, the exceptions are all listed underneath here. Okay, exceptions allowing. I'm not going to go there and go through the exceptions. I'm going to allow you guys to do that on your own. I do want to mention, because we were asked about these two, which means I can skip the question in the question and answer section. When you're looking for written paper claim instructions, if you do happen to have to file them, please make sure that you scroll down and you're going to go to the lower chapters. You're going to go to 25 and 26, completing and processing the claim form, completing and processing the 1500, 1450, 1500. Now, the reason that this is important is because if for some reason your electronic system breaks, you can default to filing paper claims for a short period of time while you get it fixed. That's the situation that actually came up in the question. So I just wanted to bring you to these two data sets so that you're aware of which data set you might need to look for. All right. One other thing which will lead me to the next section is called Bill the Patient, which is actually going to be your next slide. But before I do that, I do want to scroll down a little bit more and say, okay, as we get down in here, there's going to be a chapter in the benefit, oops, sorry, I'm in claims processing, sorry. You're going to want to go to a new section called the Medicare Benefit Policy Manual. Remember I said you have to bill the patients for things that Medicare never covers, excluded in the law. That's what 100-2, the Medicare Benefit Policy Manual, explains what's included, but it also has one very interesting chapter that is an exclusion chapter. So for the most part, you've got 16 inclusions with one exclusion chapter. So for those of you that ask where you would find information on excluded, never covered because the law said no, this is the chapter you're going to go to. You can read through all these different things. It'll tell you about all of those different items that you need to know. Okay. So that is the first item for the next slide, which is actually bill the patient. So yeah, you're going to bill the patient for any non-covered items. That's where we're going to utilize that section of this, the manuals and make sure you get that information. Next, do you need to bill the patient deductible, copay, and coinsurance? And the answer is yes. We talked about that briefly. If you don't bill the patient for something, then this can cause legal issues. Now, keep in mind, if you've billed them and the patient came back and said, I can't afford, this is my situation, that's different. You can make a decision by decision or a case by case basis, or have standing rules that apply that say, hey, if this is the case, but you did bill every patient the same. If you don't bill the patients the same, the problem is that Medicare can look at that and say, why aren't you providing the service for free? How are you not giving a kickback? How aren't you encouraging that patient to come to you? So please bill the patient for all of those types of services. Again, I already went through the question related to that, so we'll move on, which does bring us to our next question and answer session. And I do want to talk about one question pre-submitted, then we're going to flip back to see if you guys have anything in the chat. First question, or the last pre-submitted question I have for this section, is what are the most common mistakes coming from the providers that are causing claims processing issues? So what I did is pulled the top 5 issues, most common mistakes. I didn't sort them in any way, shape, or form. I didn't say claim form type or anything like that. These are just the top most 5. I did a 3-month period starting in January 2025 that went to the end of March 2025. Believe it or not, the number 1 most common mistake is that people did not view eligibility and make sure that it was checked and make sure that everything is there. And so that's in our portal, and that's 328,085 claims just for that. Should have went to a Medicare Advantage plan. You didn't check your eligibility. The next one is claims needed more information for adjudication, which means this encompasses a broader picture because the remarks code actually explains this reason code, but this was 300,205 claims. The next one is interesting to me because it's a duplicate charge paid on claim, and it gives the actual claim number. This was 200. So if you want more information on duplicates, we do recommend that you come later on and you check out the webinar coming up on that. The next one is non-covered items. Now, we do understand that non-covered procedure codes are sometimes billed. Why are they billed to Medicare? Does anyone know? Well, what if they need to go to Medicaid? What if they need to go to a secondary insurance? That's fine. Even though we have 138,851, we do understand that, okay? Then the last one is duplicate charge in processing. This is my favorite one. If it's in processing, don't submit a new charge. All right, so if it's in processing, please make sure that you're waiting for that to process fully through and that you're waiting for everything to happen there. All right. So let me stop for 1 second. I keep talking about this magic portal. Go back to our website. The magic portal login is right here on the top of our website. Our website is wpsgha.com. It's the very first one I showed you, where I showed you where to find those live. Now, this portal is a static piece of information unless you log in. It is the Secure Net Access portal. You log in, you can get eligibility information, claims information, a lot of different pieces. I will tell you that if you're looking for things like eligibility, it's not just do they have Medicare Part A or Part B. It is things like, do they have a Medicare primary payer? Do they have a Medicare Advantage plan? So the portal user manual will really help you. Yeah, let's scroll down here a little bit. When you go through, you can see all the different pieces, and I'm just doing a fast scroll. So if you don't like that, please look away. One of the things I like to do is tell people to come into the patient section, check out the eligibility. Now, this is not going to be all your transactions down here. This is your claim stuff, but this is just eligibility. And you can scroll through and find out, hey, what do we use? It's a 270, 271 transaction to the common working file, which is the feed from the Social Security Administration. They feed into the common working file, and then we take it off of there. This kind of explains all those different pieces and what you're going to find. You can see again, supplemental insurance versus eligibility. And then under eligibility, which is the one, here's all the different pieces of information. So I would really recommend taking a look at that. With that said, Karen, I'm going to stop for a second and see if we have any questions in the chat.
We did receive a question in the chat. Are you able to hear me?
I can hear you, yes.
Okay, sorry. There's been some audio issues with both of us, so hopefully everything's up and going now. The question we got in the chat is, can we bill the patient when they didn't tell us they had an insurance or Advantage plan care and the bill is denied because it needed a PA?
So I'm going to answer a couple ways for this. So if it's a primary insurance, so if it's before us and they need a PA, you can bill us with their denial and we'll make a decision on whether or not we're going to pay. If it's an Advantage plan, that is a replacement plan. Remember, that's Part C. If it's denied for PA, that is going to be based on the plan's responsibility as assigned. So we cannot comment on that. We will have to refer you back to that Medicare Advantage plan. But in the most part, yes, you can bill the patient for that. I just can't say we're 100% guaranteed because each Advantage plan may have different criteria for that. Any other questions?
Nope, that's all we've had at this time.
Okay. Let's go ahead and go on then. So what is our responsibility from Medicare? So Medicare, which is the Center for Medicare and Medicaid Services, falling under the Department of Health and Human Services, falling under the President, assigns a Medicare administrative contractor to process claims and gives them certain responsibilities. And that's what we're going to talk about in this section. What is us as the Medicare administrative contractor responsible for? First, we're responsible for determining whether or not it's ours to process. We'll talk a little bit more about that. But what that means is, as a Medicare administrative contractor, we have to look and see, should it be an Advantage plan claim? Should it be a variety of other things? That's our first responsibility. The second responsibility is to make sure that we follow the Medicare regulations. This is in the Social Security Act under Title 18. If you've never looked at Title 18, there is a lot of information out there. This incorporates everything from who can be eligible to what services are eligible. Title 18 is huge. And how CMS does that then is says, okay, under the Social Security Act, we're going to make the internet only manuals, which are going to be our day-to-day operating instructions. I already showed you those, but that's how we have to make sure we're following everything. Now, under Title 18, they do the Code of Federal Regulations, which actually takes the regulations and codifies them. That's all it's doing. This is how this should work. And then what CMS does is takes things from the CFR, the Code of Federal Regulations, and moves into the Internet Only Manual, which is our day-to-day operating instructions. So we as a contractor have to follow all the way down through. But guess what that means? You as a provider must also do the same thing. You're responsible for knowing that. When we do that, we then have to look at it and say, hey, are we processing your claim? While we process your claim, we must always look for electronic submission edits. What are we trying to do when we look for electronic submission edits? We're trying to make sure that the claim should be entered into the system in the first place, which is to protect the trust fund. We're ultimately trying to save money. Then we have to look for what we like to call our validity edits. Is the patient's number right? Is the provider number right? Those basic things that will stop a claim from processing. On a 1500 or 837P, this is called an unprocessable claim, and you must submit a brand new claim form and start it all over. On a UB04 or 837I, this is called a return to provider claim, and you must go into the system and correct it. If you do not have direct data entry, which is how you would actually enter the system, then you must submit a new claim. Okay. The last set of edits is medical necessity edits, and these actually cause claim denials. These are the ones that you typically have appeal rights with and all those types of things. It's the edits that will actually allow us to process the claim and say, no, no, this isn't right. So we want to make sure that you understand each portion. One of the questions we got in is we continually submit electronic claims, but we could never see them in the system. That means that electronic submission edit failed. It did not enter the system. So if you call customer service, they cannot help you. They cannot see it either. You have to contact our electronic data interchange department and get information from them. If you search electronic data interchange or EDI contact information on our website, you'll find the numbers that you need. All right. So how does that work? Well, first, things that happen is you, the provider, or someone within your organization, put a claim onto our bulletin board. We look at it to make sure, hey, we accepted it, right? Nothing major. All we are trying to do is say, yep, we got it. That's a 999 report. Then the next day, we're going to post a second report. And this is the electronic pre-pass edit report saying whether or not we accepted it into the system. So there's two different reports. And yes, you do need to check both. One, did we actually get it? Two, did we accept it? Once it's accepted into the system, it does begin to show up. This is where we can begin the processing portion. And this is where it hits the validity edits. Again, is it the right Medicare number, the right Medicare name, all those kind of things for the patient? Are we looking at anything from there? It'll move from validity edits to medical review edits. Not everything stops in medical review. Actually, over 90% of our claims never stop during the medical review or the validity edits. They just move right through them, kick it right out. Then you're going to see a red box on my screen, and it's the middle on the bottom row. It's called the payment floor hold. We have to hold a claim for a certain number of days. This is called the payment floor. Now, if you submit an electronic claim, it is 14 days. If you submit a paper claim, it is 29 days. But keep in mind, we always have 30 days to issue the payment on a clean claim before we begin to issue interest or anything else. So we do not have to issue payment on the 14th or 15th day. If we held it until 21 days for an electronic claim, that is okay. Okay, that is okay. That's what causes some of those actual duplicates coming in. And of course, the last thing we're going to do is issue a remittance advice. This will come with or without a payment. So again, if we held money back for anything, for an overpayment, or it went to patient deductible, those would be without payments. Other times it will come with a payment. All right. Let's move on. Let's jump back for a second. We're going to talk to the medical review portion, which is our development portion. If you're asked by any contractor, whether it is prepay or post-pay medical review, and you don't respond, you will automatically lose money. So please respond. If you do not respond to the contractor during the provider enrollment process, your enrollment will not be completed and you will have to start over. Don't do that. That just makes a lot more work on everyone. So anytime anyone's asking for something, it's under review, whether it is a claim or, again, like I said, your provider enrollment record, all of those types of things, please respond. Okay. We do explain on the remittance advice what's going on. So that means that you get to look at it, but there are things that are not incorporated on the remittance advice, such as return to provider claim. You'll have to go into the direct data entry system to see that. An unprocessable claim would be, but again, they're two different systems and they're used differently. So it's not processed. We will tell you also on the remittance advice whether we paid a claim, why we denied it, or why we applied it to patient responsibility, deductible, co-insurance, copay. All of that gets explained in that way. Now, the patient gets a summary notice, and this is the question that made me build this slide. When we explain to the provider and we send you a notice called the remittance advice, does the patient get the notice at the same time? And the answer is no. Patients receive quarterly summary notices with all processed claim. This means you as a provider can actually bill them in essence 60 or more days before they get their summary notice, which is why we like to tell you to refer them back to the patient portal on medicare.gov so they can look it up. So hopefully that answers the question on why your explanation is different than theirs. Also, one of the things that we do as your Medicare administrative contractor is do that initial appeal or that initial redetermination. We look at those to review those claims decisions. You can also do a reopening, which is not a part of the appeals process. It is a separate function or piece, but it is something that we do. All right, so hopefully we got through all those questions. I'm going to move on just to the final question here. We'll go through some pre-submitted again, and then we'll get going. Oops, sorry. Um, I did show you the resource slide. Not a big deal. It is just a bunch of list of resources that's available to you. So someone asked us about occurrence codes versus occurrence span codes. And the difference is an occurrence code does not have a date of span or doesn't have a date associated to it. It does describe a specific event related to the billing of a service on a UB04 or 837I claim. However, an occurrence span code is the same kind of 2-character code. The difference is it does have a period of time related to it. So it's similar to an occurrence code, but not exactly the same, is that it does have a data time to it. Um, I'm not going to go through the entire SNF billing process. Sorry, that's just too much. I will recommend that you take a look at our YouTube channel for that. We do have an encore set of lists that talk about SNF billing in particular and all the different types of items that go with it. It was just too complex for this education. One of the questions that came in, and again, we're going to talk about a UB04 or an 837I, is a tape to tape field. And what does it mean? Well, the tape to tape field is used to indicate whether a claim posted to the common working file. If it went to the common working file, it will be blank in the tape to tape field. If you happen to see an X, it means it didn't post. This directly affects what you can and cannot do. For instance, if it never posted to the common working file, submit a new claim. That's what you're going to do. If it did post, then you may need to correct the claim in DDE, but there's a lot more information that goes with that, and I don't want to get into all of the intricate details of that either. When replacing a claim that has been replaced a few times, which DCN should I use, the first one or the last one? The claim is not canceled. Again, this is a UB04 837I question. In most cases, you will use the most recent claim. Unless the most recent claim happens to be a duplicate, then go back to the original. I'm not sure when you say replace what you were replacing them for, what else has occurred through the edits system. So I can't really tell you for sure which one to use without knowing more information. We were asked for hospice billing, and that's literally all they said, hospice billing question mark. I don't know what you need from that, so give me some more information. But remember, WPS does not handle hospice claims. That's a separate MAC. I was also asked for inpatient rehab claims. That's the whole thing. That's the whole thing I got as IRF claims. I don't know what you're looking for on a new to Medicare claims. All the information was applicable. All right, we're going to stop for a second here and see if we had any questions that I didn't answer yet in the chat.
Tom, we did have one question. Who would we contact if claims are not crossing over from Medicare to secondary payers such as Medicaid?
Oh, so a couple of recommendations going on with this one. One, if you want to know why the claim didn't cross over, such as like, does it have the right information? Is something not getting translated? Then you need to start with our customer service, and they need to be able to look at the claim and indicate what's exactly causing the crossover. Now, depending on what's causing the crossover, it could be electronic data interchange. It could be our customer service. So it's really hard for me to give you more with that because I don't know the exact reason why it's not crossing over. But let me give you an example. There are there are supplemental plans such as Medicaid that you have to put information on the claim, and if that information isn't coming through to us, though you're seeing it on the claim, that's electronic data interchange. On the other hand, if you're not putting it on the claim, that's what the customer service person is going to look at. So a little bit kind of back and forth there. Not a specific answer without knowing the specific situation. That's all I have on that one. Karen, do we have anything else?
That was all we have right now, Tom.
Okay, well then we're going to finish up here. Here we go. I already said this before, but this is just a slide of some different resources. Again, you'll see the Medicare Benefit Policy Manual, Claims Processing Manual, great things for you. The Program Integrity Manual, a lot of people ask me, or not ask me, but specifically they ask about criteria for enrollment. That's going to give you that. We also incorporated the Medicare Learning Network on-demand courses. I just think they're good ones. If you're getting started and you're not really sure where to go with a claim, these will help you out there. You will receive an email in just a few moments. The email will come from our system. This system is the WebEx system. It will contain a survey link at the top, which is the first box. It's also going to contain your certificate, which has contact hours. This is what we use for you to translate to CEUs. We do not issue CEUs. That's a governing body. So please make sure you open this email, check it out. If you dialed in, I'll tell you how to send me the information in just a few moments. Oops. If you have follow-up questions or you need to send me the dial-in information, please feel free to do that. We do ask that you send that to WPS period GHA period education at WPSIC period com, or you can put the dots in there, however you want to say it. Here's what I would like you to do. In the subject line, input new to Medicare claims basics. That's all you need to do. From there, you're good. If you dialed in and you didn't enter an email when you logged in, please incorporate your phone number. We'll get you a certificate if you need it. Otherwise, your certificate will come automatically. Okay. You have 7 days to send me any other questions related to today's topic. Next, please remember to take our survey. I know that it gets to be a bit time and a lot of people ask you for them, but we really do need that information. I want to know what I did good, what I did bad, and my ugly. So by my ugly, I simply mean my PowerPoint. Did you like my presentation? Were the websites that I took you useful? Were the demonstration portions good? What did I do well? What could I improve on? And then what else can we do with the presentations to help you out? A couple of ways you're going to do that survey. One, Karen put a link in the feedback. Click on it now, take the survey while I finish up talking. Two, once we close the webinar, you'll see a pop-up box. It's going to look like the lower one on the screen. This is not spam. It's not malicious in any way, shape, or form. It is us directing you to our survey. Please look at the destination site. It'll say CMS Mac Fed Ramp. You can see it right here, and that'll help you out. Also, if you're watching this in an encore, we still want you to take this survey, but we're going to give you a different form. We're going to give you a link and a picture like this. So please feel free to do that. With that said, that brings me to the end. Thanks for giving me your time today. Sorry that I went a couple minutes over, but I hope that you learned something and you got something out of it. On behalf of myself and Karen, thanks for joining us. We hope that you have a great day. We look forward to your survey comments, and we hope to see you join us in the future. You may now disconnect.